Good morning. Thank you for having me here today. I'm going to spend the next 20 minutes or so giving you an overview and an update on cardiac allograft vasculopathy. I'm Sern. I'm one of the cardiologists at the Queen Elizabeth Hospital in Birmingham. I have no declarations for this presentation. I'm going to start with a quick recap of what this condition is. This was actually described almost 50 years ago by the team at South Africa when they examined the heart of the second heart transplant recipient after he died. And they found quite significant and what was described as universal luminal narrowing when they examined the coronary arteries. At that time, Thomson felt that this was related to the metabolic milieu of the recipient and attributed these changes to cholesterol and lipid, and went as far as suggesting that patients with ischemic heart disease may not be suitable candidates for transplantation. We have moved on quite a bit since then. We now know that this is not just atherosclerosis, and in fact it is an interaction of environmental risk factors such as diabetes, hypertension, hyperlipidemia with significant immunological process, and it is this interaction that results in the progression of the development and progression of vasculopathy, and also presumably some of the differences in the phenotype of these conditions. So, for example, in vasculopathy, we often see distal coronary artery disease and also microcirculatory changes. Collateralization and calcification tends to be uncommon, and one of the key characteristics is the concentric diffuse nature of the condition, with no remodeling of the artery, unlike conventional atherosclerotic disease, to compensate for the intimal thickening, and this results in quite significant luminal loss. So this is an example of a patient who sadly passed away from vasculopathy. She had a very rapidly progressive vasculopathy and presented with cardiac arrest. And you will see the diffuse nature of this condition and also the different patterns with, for example, in the circumflex artery, a rapid taper in the vessel diameter. Which leads me to the diagnosis and classification of this condition. In 2010, the ISHLT came up with a document to describe the nomenclature of vasculopathy. And you will notice that this is primarily an angiographic classification system. There is some mention of graft function, such as LVEF, but this is largely a description based on coronary angiography. So this is based on the degree of stenosis, which vessel it is involved, and how many vessels are involved. So this was drafted at a time when coronary imaging was not in widespread use, and certainly coronary flow physiological assessment was far from routine at that stage. So an example of severe cardiac allograft vasculopathy with left main stem involvement, you see that beyond the left main stem, there is also fairly diffuse coronary artery disease. And I should emphasize that even with nitrates, these vessels fail to dilate. So it's not a spasm, which should be also excluded when we see significant coronary disease. On OCT, coronary imaging, you will see quite extensive thickening of the intima associated with luminal loss. But beyond the epicardial coronary arteries, we know that even the microcirculation is important. We know that these changes occur, but we have also known for some time that these changes are prognostically important. This is a histological study of biopsy specimens and they studied the microvascular changes, and patients with microvascular abnormalities had a worse survival freedom from cardiac events in the longer term. And now with more widespread use of coronary flow assessments, pressure and flow wires, for example, we're able to quantify the myocardial blood flow during angiography. This is a study that correlated the changes on histology, so changes in the arterioles and capillary density, and correlation with invasively measured flow characteristics in the coronary arteries. So this instantaneous hyperemic diastolic velocity pressure slope appear to correlate reasonably well with arteriolar changes and also loss of capillary density, suggesting that this may be a useful parameter in the assessment of microvascular changes. Others have also examined the use of what we call wave intensity analysis. Wave intensity analysis requires simultaneous pressure and flow measurements during the catheterization. And we're able, using wave intensity analysis, to characterize flow into forward or backward traveling waves, and also compression or decompression waves, depending on whether pressure goes up or goes down. So the backward decompression wave is a characteristic of the coronary flow physiology and is generally attributed to the diastolic capacitance change related to the microcirculation. So the larger the backward decompression wave, the better your microcirculation is. So here the authors demonstrated that the reduction in the backward decompression wave, the BDW, correlated with loss of capillaries, but also very interestingly predicted the subsequent development of epicardial coronary artery disease. And this is a relationship between the backward decompression wave, the magnitude of this wave, and the subsequent severity based on the ISHLT nomenclature, the severity of the vasculopathy few years down the line. So the microcirculatory changes appear to precede the subsequent development of epicardial coronary stenosis and the severity of these changes as well. And again, the instantaneous hyperemic diastolic velocity pressure slope, which appear to be a measure of microcirculatory changes, also predicted the subsequent development of severe vasculopathy. So the data suggests that the microcirculatory changes occur early and may well precede the subsequent development of epicardial disease. This is a more recent study that characterized the microcirculatory changes and also the FFR, so more of a epicardial coronary flow at baseline after heart transplantation. This was taken at about 7 weeks post-heart transplantation and reassessed a year after retransplantation. And this study is interesting in that it showed baseline microcirculatory changes, which in many patients resolved at follow-up, but also that patients with no microcirculatory changes who then subsequently did develop microvascular dysfunction at 1 year follow-up. The number of patients with abnormal FFR were relatively small. And this is a summary of their results. And firstly, I would just want to point out the definitions. So reduced FFR is based on conventional criterion of FFR less than 0.8, and microvascular dysfunction was defined by a high IMR or a low CFR in the presence of a normal FFR. And normal physiology is basically the absence of either the reduced FFR or microvascular dysfunction. So here the authors have shown that the presence of either reduced FFR, which again is a very small proportion of patients, and the microvascular dysfunction as defined by their technique is associated with increased risk of death or retransplantation at 10 years, again suggesting that the microcirculatory changes that occur at a year are significant predictors of late outcomes. Now, coronary angiography and intravascular imaging or intravascular assessment of coronary flow is clearly invasive and carries risk, particularly with instrumentation of the coronary arteries, and it is reasonable and entirely logical to consider non-invasive assessment. And I just want to highlight a couple of studies. This is the study by Sharon Chi that examined the role of PET, quantified myocardial blood flow, both at rest and at stress. And they have found that PET scan, particularly with a combination of parameters such as stress myocardial blood flow and also the corrected myocardial flow reserve, may be sensitive and specific in terms of identifying angiographic vasculopathy. A combination of some of these parameters may be useful. So a PET scan certainly holds promise in assessment of vasculopathy non-invasively. I'm also going to talk a bit about cardiac MRI here. So this is a summary of 4 studies, various sizes and various duration of follow-up that examine the role of cardiac MRI. And the interesting thing about cardiac MRI here is are 2 things. The first is that the myocardial perfusion reserve, so a way of quantifying myocardial flow, blood flow, may be associated with the subsequent development of vasculopathy and its progression. So again, suggesting that abnormal flow at baseline may well identify subsequent development of vasculopathy. And the second finding of interest is that myocardial scarring by late gadolinium enhancement may be prognostically significant, and perhaps even more so than the angiographic severity of vasculopathy. So from an MRI point of view, the late gadolinium enhancement, not just the presence, but also the gadolinium enhancement as proportion of LV mass may be a prognostic value. So it suggests that once you've developed myocardial involvement, your prognosis may well be worse, even adjusted for the severity of the angiographic coronary artery disease. So it may certainly hold promise as a prognostic tool. What about progression? Can we identify or predict the progression of vasculopathy? And this may be useful because in some patients where we believe may be at high risk of a progression of vasculopathy, we may wish to have more angiographic surveillance. And conversely, if a patient is at low risk, we may not need to consider such aggressive angiographic surveillance of the coronary arteries. So some degree of tailoring of these assessments rather than a standard uniform protocol surveillance with angiography. This is a very interesting study, a large international study of transplant recipients. And the authors defined 4 different trajectories based on the presence of vasculopathy, again on angiography, using the ISHLT nomenclature at 1 year and the subsequent changes over time. So here they have 4 trajectories. The first trajectory have very good 10-year survival. They have no vasculopathy at baseline and remain largely free from vasculopathy at follow-up. Unsurprisingly, the survival is very good. And in trajectory 2, they start with no vasculopathy, but subsequently develop some degree of vasculopathy, usually after about 4 years or so. Again, they have pretty good 10-year survival. But once you start getting into trajectory 3 and 4, where they develop early vasculopathy at year 1, the prognosis at 10 years tend to be much worse, particularly if there is rapid progression, as shown by my first case earlier on, when they develop vasculopathy within the first few years of heart transplantation. The 10-year survival is generally quite poor, at about 50% if there is rapid progression, shown here. Now, the authors identified 6 parameters that may be of value in predicting the trajectory. And in fact, there is an online tool that you may be able to access to try and assess the probability of the different trajectories. So here the authors have provided a few case examples. In case 1, for example, the the patient has a very high probability of being in trajectory 1 or 2. So generally speaking, a very good prognostic group. You will see that the 6 parameters here are divided into 4 categories: the donor characteristics, the recipient immunological factors, and also the lipid profile. So in case 1, for example, you have a young male donor who is a non-smoker, and the recipient had no hyperlipidemia, no rejection, and no donor-specific antibodies, and the trajectory here is very good. But in contrast, if you look at the case 6 or case 8, for example, the likelihood here is that the patient is going to have a very high probability of poor 10-year survival because of rejection and or donor-specific antibodies, particularly also the presence of vasculopathy at a 1-year follow-up. So using this tool, we may well be able to tailor the surveillance strategy for vasculopathy, and perhaps even tailor our management of these patients, which I will cover next. So with regards to, we have a few medical therapy that are well established. So statin should be used universally in all heart transplant recipients, and it is believed that the benefit may be partly related to the pleiotropic effects of statin rather than just lipid lowering. Mycophenolate is now also a fairly standard part of the immunosuppression regime replacing azathioprine. And everolimus or sirolimus may also slow or delay the progression of vasculopathy, certainly based on coronary imaging studies. CMV historically has been a risk factor for vasculopathy, but in the current era of fairly routine valgar encyclovir prophylaxis, this relationship between CMV status and vasculopathy appear to have diminished, except perhaps for patients who suffer from breakthrough CMV infection. There is some early intriguing data to suggest that aspirin use may attenuate the development of allograft vasculopathy, but this will need to be confirmed. And then there are also ongoing studies on more aggressive lipid-lowering therapy in potentially delaying the development of vasculopathy. Not all these studies have been positive. This is an interesting study of rituximab used in the early post-transplant period as part of the immunosuppression management. And I should emphasize that this is not the use of rituximab in the context of PTLD, for example, but the early use of rituximab appear to predispose patients to development of vasculopathy later on. So we should be cautious about the use of rituximab in the early post-transplant period routinely. What about? I'm just going to focus on revascularization with PCI, and these are some of the studies that have examined, I guess, more contemporaneous studies using drug-eluting stents. Now, although PCI is largely efficacious, there is still a reasonably high in-stent restenosis rate, but more importantly, a high target vessel and non-target vessel revascularization rate. So I draw your attention to the study by Cheng, for example, who has shown a 2-year target or non-target vessel revascularization rate of almost 40 and 55% respectively. So these are very high rates of reintervention. And crucially, none of these studies have shown any real evidence of survival benefit with PCI in vasculopathy, even with drug-eluting stents. Retransplantation may be considered in selected patients, particularly if they have developed significant graft dysfunction, generally speaking, an ejection fraction of less than 45 or 40%. And this data from the ISHLT registry suggested some survival benefit in these patients. So just to pull it all together, I'll with my overall approach. We now perform angiography routinely at year 1, and we will try and quantify microcirculatory flow using a coronary flow assessment. We will still classify the patients based on the epicardial or the angiographic appearances, but also incorporate the cardiac function into that. We have not routinely employed cardiac MRI, but certainly the presence of reduced ejection fraction or restrictive physiology would suggest a higher risk profile. The management here is shown on the right. In higher risk patients, we would now routinely consider the addition of sirolimus into the immunosuppression regime. Revascularization is used fairly conservatively to discrete vessels, usually in association with symptoms, and retransplantation only in a very small proportion of cases. So this is my kind of summary of the data that we have. And I'll conclude with this slide, which pull together the various strands that I've covered this in the last 20 minutes. And the final point here is that I think it is now time for us to revisit the classification of cardiac allograft vasculopathy. Thank you for your attention.